is Dr. Ankur Singh. Dr. Ankur Singh is here. Dr. Ankur Singh. He will talk on case Chronicles, Tubercular, Posterior, Uveitis, Unraveled.
Very good morning to you all on this Monday morning. So, Dr. Ankur, I'm going to talk about posterior tubercular uveitis case Chronicles. So, my talk is going to be more about cases. And thank you AIOS for giving me this wonderful opportunity. So, as we all know by now, the tubercular uveitis is a form of extrapulmonary TB associated with significant morbidity. There are two possible pathophysiological mechanisms by which we acquire ocular TB. One is the active hematogenous spread, that is choroidal granuloma. Second is delayed type of hypersensitivity seen as serpiginous choroiditis. Posterior uveitis per se can be solitary tubercle, merely choroidal tubercles, choroidal tuberculomas with or without subretinal abscess, serpiginous like choroiditis, and trabecular retinal vasculitis. So now comes the diagnosis. Diagnosis of TBU is challenging. Why? Because it's difficult to demonstrate acid-fast bacilli on smears or histopathology or intraocular specimen. So you would be surprised to know till now we just have very few studies which have isolated TB bacilli from the eyes having any kind of trabecular posterior uveitis. Molecular diagnostic techniques like PCR are very good, but they still have a low sensitivity because there is a low bacterial load in patient of trabecular uveitis. So we are left with immunological tests which are quantiferon TB gold or commonly called as IGRA. So what I would like to say is the diagnosis of trabecular uveitis is mainly presumptive based on the ocular signs consistent with trabecular uveitis. So there have been different treatment guidelines. We have course guidelines, we have index TB guidelines, and what do they say? They say that if the patient has serpiginous choroiditis, you have either of the immunological tests positive or radiological test positive, or you have any microbiological evidence, you can start an ATT. So these are the guidelines to when to start ATT because ATT has its own problems. In patients with trabecular granulomas, the both immunological and one radiological evidence has to be positive. Why? Because granuloma is usually associated with an active trabecular bacilli. In active retinal vasculitis, if immunological test, that is Mantoux or TB gold, and one radiological test is positive, you can start a patient with ATT. And at the same time, if the patient who you find this test positive and does not have an active retinal vasculitis, don't treat it with ATT. Panuveitis, if again immunological with radiological test positive, start ATT. With the help with the ATT, you should always start with steroids because it can lead to worsening of the trabecular uveitis in few of the patients. So this is one case example of trabecular serpiginous choroiditis. You can see a peripapillary region. We did an FFA in this patient. What do you find? That there was this inferior active area circled in blue. So these are hypofluorescent in the beginning. They tend to leak in the late phase. One other very good investigations to look at the patient of serpiginous choroiditis is autofluorescence. So if you have a stippled autofluorescence or in complete autofluorescence, you are looking at an active lesion. So when this goes down and it becomes completely hypoautofluorescence, this is the time you must understand that the lesion has healed and you can stop the treatment. This is another patient that came to us. If you can see, there are few active lesions, there are few healing lesions. This is how it happens in serpiginous choroiditis. The inferior ones are active. And at the same time, there's a spot in the fovea which is also active. So we thought of, instead of giving systemic steroid, we thought of giving this patient an intravitreal Ozurdex. And he responded very well. So from the vision 6/12, when we thought he will not gain much of the vision, looking at the picture profile of the retina, he gained 6/9 vision. So Ozurdex with ATT because he was Mantoux positive on quantiferon TB gold as well as CECT chest positive. Then there is another patient who was again Mantoux positive, quantiferon TB gold positive, chest X-ray was negative. So if you see, you have an active edge which is fovea threatening. So when it was fovea threatening, we had to deal it in very aggressive way. So we gave the patient IV methylprednisolone. But you see, even after 3 doses, the patient did not respond to the IV methylpred, which ideally should. So we thought of adding one more agent, intravitreal methotrexate, in this patient. So this was IV methylpred, 5 doses with MTX, intravitreal, and followed up on the oral steroids with ATT. He responded very well, and you see in the last picture, the lesions are pretty well healed. Now this is different entity. A patient came to us with, this inflammatory BRVO with vasculitis. He was Mantoux positive, quantified on TB gold positive, X-ray chest positive. In fact, bronchoalveolar lavas that were done in this patient also turned out to be positive for TB. So we started this patient on ATT. We gave this patient an anti-VEGF as well as steroids. He responded very well. We did the scatter laser in the areas which were non-perfusion areas, because we know by now that trabecular uveitis is an occlusive kind of vasculitis. So we treated this patient. We were pretty happy. He was doing well. He has 6/9 vision. And mind it, this is only a one-eyed patient. He came to us later on, lost to follow-up with this vitreous hemorrhage. So one take-home message from vasculitis, trabecular vasculitis, is that these patients tend to develop collaterals less. And when you treat them initially, you have those BRVOs, and you tend to miss upon the CNP areas. And these are the patients which tend to go and develop NVDs and vitreous hemorrhage. So you need to follow up the patient regularly. When do an repeated FFA after some time, do an accentuated laser, and the patient tends to do absolutely fine. He is a 6/9 vision, and he's following well. All the anti-VEGF that is coming is taken care of. In fact, these kind of patient you can also take upon FFA on the optos, because you also need to treat those peripheral lesions if you cannot identify them clinically. See, trabecular posterior uveitis have sequelae, and this is a patient who came to us on the follow-up which developed a CNVM. We did an FFA, we did an OCT angio. You can clearly delineate this, CNVM complex. We gave this patient anti-VEGF only, because he was already treated. He had healed lesions. So he responded very well to anti-VEGFs, and he's doing pretty well. Now this is one case I want to put to the house. You see these orangish lesions. As we have grown up, we have realized that those few orangish lesions are, we think of sarcoid. When you look at the choroidal granulomas, which are of trabecular etiology, they usually are whitish. So orangish means sarcoid, whitish means TB. At the same time, you can see this kind of retinitis kind of picture with an obliterative vasculitis. So we were quite confused, because now we did an investigation in this patient. The Mantoux came out to be 18/18. Not too big, not too high. Quantified on TB gold positive. History of TB contact, normal ACE levels, and CCT and X-ray chest not conclusive of TB or sarcoid. So because as per the guidelines, if you are thinking of an choroidal granuloma, if you see on the OCT picture 948 microns, this is a granuloma over here. Because we didn't have the evidence of TB to start ATT, we have not yet started this patient of ATT. We just treated this patient on steroids, and he's doing pretty well. And we have taken care of the CNP areas with the laser. So at the end, I just would like to say is that 90% of the patient of ocular TB do not have systemic evidence of TB. Posterior uveitis is the most common anatomic location for ocular TB. Serpiginous like choroidal is the most common phenotype of choroidal TB. Most common cause of occlusive retinal vasculitis in our country is TB. CT scans are more effective in detecting the healed and old pulmonary lesion than the X-rays, especially the HR cut CTs. Steroid is usually given in a tapering dose for 6 to 12 weeks, and a watch on systemic side effect of ATT should be kept while giving ATT. Thank you very much for the patient hearing. I thank my teachers who have helped me to become what I am today. Thank you.
Thank you, Dr. Ankur. Just one point, like ATT, you yourself advise or you take help of a pulmonologist?
Ma'am, now what happens is, how do we practice in Delhi and how we used to practice in PGI is a bit different previously when I was there. So it's always advisable to take the help of an internist.
Yes.
And we still, in Delhi also, we never start the ATT from our side. The dot center that starts the ATT. Yes. Now, what comes to the prescription? So we always send it to the pulmonologist. In certain cases, when pulmonologists are dicey, because they feel that they leave it to us.
Yes.
The file comes back. They say,
exactly.
if you have a strong clinical suspicion, then you can start the ATT. That is where these guidelines come into play. Now we have index TB guidelines and we have course guidelines. The last case which I showed you was again this dilemma. As per the guidelines, there was no indication, as per the guidelines, there was no indication of TB.
Because
is what-
pulmonologists, they don't start with only Mantoux or TB
Yeah,
Gold
absolutely, ma'am.
positive.
That's
They
what I'm
want
saying.
always some chest finding or some frank finding in
This
favor
is-
of
ma'am,
TB.
this is how they are trained to look at the patients.
Exactly.
We are trained to look
So,
at the ocular features.
Our direct involvement is needed for them to start ATT.
So you should always prefer to start with the help of an internist who could be a
Exactly.
physician or a pulmonologist. But
Yeah.
if you don't get an, your patient, you are worried about the patient, you have the guidelines to support your claim.
Yeah. Okay. Any other questions?
So ESR, C-reactive, ESR per se is a very, vague indicator. It can be raised in so many, a patient of anemia can have a raised ESR. CRP maybe, but then CRP does not have a direct role in, tuberculosis. Because as I said that most of the cases might just have no systemic evidence of the TB, just the ocular. And ocular TB per se is not going to raise the CRP that much. On the other side, when you're looking at those AION patients with giant cell arteritis, you tend to have a CRP high. So they can be values which are slightly higher, but then treatment based on CRP, no. Treatment based on your presumptive diagnosis, the investigations, and the these immunological tests.
Okay. Thank you, Dr. Ankur.
Thank you.
So we'll go. You have one question. Okay.
So I get your question. So what happened is I'm just going to share a case which was an just anterior uveitis, which came out to be positive for tubercular etiology. So I've rarely encountered these kind of cases, but then I have seen in my previous institute that this patient was given a ATT, repeat ATT, because after one ATT there was a remission of the disease and this. But at the same time, when you are looking at this patient, you should also look at that, is this an MDR patient? So if they are MDR patient, you need to titrate your drugs. So this is where the pulmonology is absolutely required.
Okay.
Don't-
We'll actually
Yeah. Thank you.
we'll sort out.